Thanks again, and I'm sorry, Dr. Toribio was supposed to be here. She couldn't make it, but she's sorry about that. But she did all this work. She did a tremendous job at it, so I give the credit to her on this. This was also presented at CROI, and we asked whether it was fine to present here, and we were told yes. So this has been presented at CROI, but we thought it was an oral presentation at CROI. You saw this. I showed you cardiovascular disease prevalence, and I mentioned before that there's a mannose moiety on a dextran spine that leads to specific interactions on macrophages. I mentioned the stable plaque, high-risk plaque earlier. So we've shown before that tilmanocept, which we use with SPECT-CT imaging, is a novel imaging modality that allows actual quantification of macrophage-specific arterial inflammation. And here we quantified this using a signal-to-background SBR ratio of aortic 99M tilmanocept compared to background muscle activity. You have to compare it to a muscle activity as a background. And the threshold you use, I'll discuss in a minute, is important. So red is hot and inflamed in these pictures. So we asked two questions. What are the differences in macrophage-specific arterial inflammation among people with versus without HIV? And then if there is a relationship and a difference, what is the relationship between this imaging and plaque volume and systemic immune activation among people with HIV? So we hypothesized in this study that people with HIV would have a higher level of inflammation, or macrophage specific, and that it might be in relationship to non-calcified aortic plaque as opposed to calcified, and in relationship to select immune pathways. So we enrolled 20 people with HIV and 10 people without HIV. They were 18 years or older, stable ART for at least 3 months, more than and no interruptions more than 2 weeks over the last 3 months. We excluded anyone with a history of cardiovascular disease, anyone using lipid-lowering agents, anyone using anti-inflammatory medications. So this is a pretty clean set of patients. And we performed fasting. Oh, sorry, I don't know why. We performed fasting lab assessments, including levels of markers of immune activation. We also did CT angiography and, of course, the SPECT-CT in these patients. So at baseline, the patients were around 55, so they were relatively young. The 10-year ASCVD risk score in this particular group was around 8, which is still modest, relatively low, and there was no difference. There was no difference between the groups. And you could see they were very well matched on lipid levels and smoking and all these other factors which could affect their arterial inflammation. So we compared this inflammation and we looked at the percent of the aortic volume with tilmanocept uptake, which was in a range between 3 to 6 times the background muscle activity. And the threshold is shown in these two graphs on the bottom. On the left, participants with HIV, and on the right, the participants in blue without HIV. And on the x-axis, you can see the thresholding. So this is the aortic background, the aortic uptake compared to the background, that fold uptake. So it would be 3 times muscle, moving all the way over to 6. So 6 is super, super hot. Even 3 is 3 times background is hot. And when you look at these kind of regression curves in repeated measures ANOVA controlling for sex, and the tilmanocept uptake was higher in the HIV participants in this very controlled experiment, HIV versus control. Sorry, this is moving on its own now. First it was slow and now it's fast. And it was particularly increased in the tail. So at the highest levels compared to the background, it was increased at 5 and 6 times, 5.5, and 6-fold times background. And you can see that in the top figure. And then we looked to see whether there was a relationship between the amount of aortic volume with tilmanocept uptake above threshold compared to the aortic non-calcified plaque volume. And that's plaque volume defined as a Hounsfield unit less than 130. And there was really an interesting relationship. The uptake was directly related at multiple thresholds to the non-calcified plaque volume in the HIV patients, and completely not related in the non-HIV patients. So not only is it inflamed, but it's an index of non-calcified plaque volume in these patients. So in multivariable regression modeling, tilmanocept uptake, the interaction term between aortic plaque volume and HIV status was significant for non-calcified plaque, very, very significant, but not for calcified plaque volume. And then we looked at different markers that were associated. First we looked at markers that might be different between HIV and non-HIV, and then the relationship. So for example, if you look at caspase-1, which is a marker of the inflammasome, it's significantly increased in the HIV patients, and it's very significantly related to the arterial inflammation in these patients. So that's interesting, and there are a couple other ones that are related like that as well, but that's the most profound one. So again, the inflammasome kind of rearing its head. And then we did flow cytometry in this, and we looked at various monocyte subsets and populations, and also at CD4, CD8 in the ratio. So you can see, for example, that the CD14, 16, let me get this straight, which one? Oh, the CD14 negative, CD16 plus monocytes were significantly higher in the HIV-infected patients, and very significantly related to the tilmanocept uptake. And that you saw very strong relationships between CD4 and CD8 in the ratio in the appropriate directions. And pretty striking given the sample sizes we're talking about here. So lower CD4 and higher CD8 had direct correlations to the arterial inflammation in these patients, as did activated monocyte subsets. So in conclusion, this study showed that people with HIV had higher macrophage-specific arterial inflammation, that among people with HIV, macrophage-specific arterial inflammation related primarily to non-calcified plaque, and that the NLRP inflammasome activation, T-cell senescence, and patrolling monocytes, those are the ones I mentioned, related significantly to macrophage-specific arterial inflammation. Again, suggesting and linking this immune activation in specific monocyte subsets and immune factors to actual arterial disease. And so I'll stop here and thank you very much. I want to just thank the people in my lab, and particularly Dr. Mabel Toribio. And this was funded by a CFAR grant from Harvard, which was very nice, and we're very appreciative of that. So thank you very much for your attention.